It's my pleasure now to introduce you Sue Goldstein. She is a sexuality educator and clinical research manager at San Diego Sexual Medicine, responsible for sexual medicine educational programming and clinical research. Mrs. Goldstein is currently president-elect of the International Society for the Study of Women's Sexual Health, as well as industry relationship chair. She also serves on the educational committee of the International Society for Sexual Medicine, as well as the educational projects and female sexual function committees of the Sexual Medicine Society of North America. She's an ASSECT certified sexual educator and an ACRP certified clinical research coordinator. Mrs. Goldstein is also the 2017 recipient of the ISSWSH Distinguished Service Award. So please, Sue, the floor is to you. Thank you.
Thank you so much for this honor. Ariel was certainly a very special person, and I think what was unique about him, well, one of the many things that was unique was that he was committed to so many societies, and it wasn't lip service. He actually was very involved with all of our societies, which is why we're all here, and I'm honored to be representing the International Society for the Study of Women's Sexual Health. This is a tragic loss for the world, for his patients, and for our society, certainly. For those of you who are not familiar with ISSWSH, we're very unique in that, unlike most societies where it starts with a core group of providers, physicians, for instance, and other people join, ISSWSH started right from the beginning that everybody has equal import no matter what their background, whether they're a physician, a nurse practitioner, a sexologist, a researcher. We're committed to spreading science, to moving the field forward to the highest level of professionalism, and to making sure that we can provide accurate scientific information, both to researchers, providers, the public, to everybody. It's a pretty special organization in that way. Oops. So sexual dysfunction, did I skip? Hang on, no, okay, sorry. So sexual dysfunctions in women basically fall into 4 categories: desire, arousal, orgasm, and pain. So first I want to share a little bit about desire. ISSWSH is known for putting together consensus groups and making publications to bring the field forward. So recently we were very involved with that. Desire is treated in the US and in Canada. We have flibanserin, that's government approved, bremelanotide. Around the world, we use off-label SSRIs, and we use testosterone. But as most of you probably know, testosterone is only available for men, in formulations for men, except for in Australia, where there has recently approved formulation for women. And one of the problems we have is that providers such as Ariel and most of you who are on this webinar, many of you who are on this webinar, have no idea how to use the testosterone properly in women in a safe way. So ISSWSH put together a consensus panel and said we need to get this information. This is based on the process of care that ISSWSH published quite a few years ago. You can see that the treatment is the CNS agents that I mentioned before, sex therapy, but in postmenopausal women and people in the late reproductive years, it's hormonal therapy as well, which is testosterone. So we really recognize that there's a need for having some guidance for testosterone. Recently, there was a huge meta-analysis on all the publications of testosterone, and based on that, the global consensus paper was written, which showed that testosterone only showed safety and efficacy for treating hypoactive sexual desire disorder in menopausal women. So that was a huge piece of information for us. And in ISSWSH, we have known for many years that testosterone is helpful in treating these women for their sexual desire issues. But to now have the dedicated proof, and the one thing that paper did not include was, how do you use testosterone in women? So fast forward, I don't know why my slides are not advancing. I'm sorry. Let's do it this way. Okay. ISSWSH put together their consensus and published the guide of how to use testosterone in women. So this talk was asked to talk about advances in female sexual dysfunction, and this is a huge advance because while the central nervous system drugs are not available worldwide, testosterone is available in most places. So to provide a safe way that women with distressing low sexual desire that was not situational, but was generalized. In other words, it wasn't because they don't like their partner, but this is the problem that desire is not where it was when they were happy with it. It doesn't matter if they have no desire or decreased desire. If in any way they're distressed by having less desire in some way or another that they used to have, they deserve to be treated if they want it. So to be able to show in a safe way how to use testosterone was really key. By the way, this publication is open access. So if anybody is interested, you can download it from the Journal of Sexual Medicine for free. Basically, the guidance is to use 1/10 of a government-approved formulation for men. This would be in the form of a transdermal patch, a gel, a spray, a cream, so that it's 1% testosterone in the formulation, so that the recipient would get 300 micrograms per day. There are other formulations for testosterone for men, such as pellets, but these can provide supraphysiologic levels when they're first inserted. IM injections are not recommended because of safety reasons. It can be too high. Orals, we don't use the same thing. Right now, the only orals that don't affect liver are much too high a dose for women. And important to note is that the compounded products for testosterone are not recommended. I live in the United States, so for us, our government approval agency is the FDA, and the FDA has written not to use compounded products. The problem with compounding testosterone, which people may not be aware of, is that it layers. So the amount of testosterone at the beginning of the container is not the same as at the end of the container. So if you want to be able to provide consistent delivery to a woman who is having such a low volume of testosterone, that lack of consistency can really make a difference, we recommend using those male doses that are transdermal that will deliver 300 micrograms per day. Blood tests are used not to determine a level of, there's not a specific level that determines this is going to make a difference for desire, unlike hypogonadism in a man where we know there is a specific level that we look at. But we need the blood levels for safety. If symptoms go away, then that's enough in terms of the level of testosterone, but we want to make sure that somebody does not go into a super physiologic range. You want to maintain them in what is basically a premenopausal physiologic range, and you need to monitor patients for any level of androgen excess. Keeping at the levels that we're recommending, you should not see any issues, but we always want to monitor for safety. These are the key takeaway messages. I'm not going to go through all of these, but these are available on this paper. So for those of you who are interested in learning more, download the paper, and this can be your go-to guide for using testosterone to treat desire. And you can, for those of you on this line who are sexologists or sex therapists, please note that we believe in a biopsychosocial approach. You can use biologic treatments and therapy at the same time. It is not exclusive one or the other. And if you look at the process of care that ISSWSH published a few years ago, this is recommended that you can use multiple approaches at the same time. So the next area of sexual dysfunction we're going to discuss is arousal. This is the other recent consensus paper or consensus area that ISSWSH looked into. So for those of you who've never heard of this, we started out in 2001, Sandra Lieblum identified persistent sexual arousal syndrome. This is a problem where women, and now we know men as well, had a constant sense of arousal with no interest. There was no desire. It was just a sense of a physiological arousal. In 2006, this disorder was renamed persistent genital arousal disorder because there was nothing sexual about it. And the implication of using sexual in the name was very distressing to patients. Marcel Waldinger looked into association with restless genital syndrome in 2009 and talked about either renaming this or associating RGS with PGAD. In 2020, we recognized there was a need for more expansive information, so we talked about renaming this disease state genitopelvic dysesthesia. Patients were not happy with anything that included genital arousal because they weren't interested in having genital arousal. It was just occurring. And so they really were unhappy with the name PGAD. It wasn't a word that they felt they could use publicly and not be shamed. There are even, unfortunately, physicians that when the patients go will say, oh, I wish my wife had orgasms all day long. I wish my wife was aroused all day long, which is really sad. When somebody has a distressing disorder that is so bad that people commit suicide every year, there's a great deal of suicidal ideation with this problem. When you're belittled by a provider saying, I wish I had that, we recognized there was a need to really get this education out to the community. So we're thrilled that the ICD-11, the new chapter on sexual dysfunction, will recognize PGAD, but this became a limitation for us in trying to develop a new name because the ICD-11 uses PGAD. So what did we come up with? Renaming this disorder persistent genital arousal disorder, genitopelvic dysesthesia, or for short, PGAD, GPD. It allows the patient to disuse the GPD term. So genitopelvic dysesthesia feels like a medical disorder and not a sexual, and so they could feel more comfortable discussing it. It also allowed us to expand what the definition was. So this is the paper, which is also published open access, downloadable for free by anyone who's interested. It gets very complicated, this disorder. We've revised the original definition because not everybody has a sense of arousal. They may have a sense of itching. They may have a feeling of arousal in their anus, around their anus, and not around their vagina or clitoris. So sometimes this feeling goes further than just their genitals, which is what Marcel Waldinger was talking about when he talked about restless genital syndrome. So by redefining this and expanding the associations, we were able to incorporate all of this cluster of symptoms under one roof, under one name, genitopelvic dysesthesia. It brings more awareness to the fact that it's not just clitoral arousal, which was what everybody thought initially. It's also very interesting to note that if you do a physical examination on these people, they will often have no physiologic arousal. What they have is a sensation of physiologic arousal. No less distressing because it is a legitimate feeling, and they will often, for men and women, will often masturbate for a great deal of time in order to relieve themselves enough that they can actually leave their homes and do something. And picture a man who has this uncontrollable orgasm and he's walking down the street and suddenly he wets himself because he ejaculates. I mean, at least for a woman, and I will say at least, but she can hide it a little more effectively than a man. It's what we thought was originally a very unusual condition, we know now affects at least 1% of society. And while 1% may be a very small number of 100, when you consider the number of people in the world, 1% is a huge number of people. And so it really behooves everybody to learn more about this disease state. We have in this paper, the experts spent 2 years developing this, redeveloping this, going back through this, and realized that PGAD has often multiple triggers, but the best way to understand it is to break it up into 5 regions. Region 1 is end organ. Region 2 is pelvis and perineum. Region 3 is the cauda equina. Region 4 is the spinal cord, and Region 5 the brain. There are psychosocial factors that contribute and make things exacerbate things. And so for the therapist, it's the really important first line therapy is helping the patient deal with the stress, because no matter what the triggers are, stress is going to make it intensely worse. And then the problem is going to be investigating and putting this puzzle together, figuring out where the triggers are, because you can't start to treat somebody until you figure out triggers in each of these sections. And so it really, I always talk about it's a puzzle, and we need to figure out which pieces of the puzzle are causing the PGAD. And once we figure out the pieces, then we can start talking about the treatments. I'm not going to go through this, but you can see how complicated this is. These are history information you need to get, what you're looking for in physical exam, the specific tests for that region, and then the treatments as of yet. This is regions 1 and 2. This is regions 3, 4, and 5. And then on the bottom, the psychosocial issues that affect all 5 regions. Take a look at this sometime when you have, when you have some idea. Since the publication of this paper, we've even identified more potential triggers and more potential treatments. Much of this has been done by trial and error. It's anecdotal evidence. While that's the lowest level of evidence, when you realize the number of people who commit suicide with this disease state, having anecdotal evidence is needed. And as long as we can, repeat this among some of the experts, we've published this. The bottom line is, you want to be able to cure the PJD by stopping the triggers, but in the meantime, you want to decrease that level to a tolerable level. If they're at a level of 9 or 10 of pain is not the right word, but if level 9 or 10, if we can bring them down to a 1 or 2, they can operate in this world. And so that is really the goal initially, bring it down to a level that they can live with. I'd like to thank the ISSWSH Education Committee for helping us organize webinars on each of those topics. We've had a webinar on the testosterone and one on the PJD paper in April and in June. And starting in July, we will be doing additional webinars specifically on one region at a time for PJD. For people who are interested, you can go to the ISSWSH site. And the reason I bring this up was that Ariel was an extremely active member of the education committee. Even when he was in the ICU, before he was intubated, he sat with his computer or his iPad on his lap, and he was participating actively in the education committee meetings. So in his memory, I ask each of you to please read these papers, learn, become better providers. I know you're all wonderful providers for your patients, but the more we know, the more we can help our patients. And in Ariel's memory, now I'm going to cry. In Ariel's memory, please do your best to learn new information, help your patients even more, because everybody needs help. Thank you.
Thank you so much, Sue. Thank you. It was such a beautiful lecture. So it was too good to be true, Myers, because in such a short time, you gave us updates, what is new, and also what is really significant for our clinical work. So thank you so much for this.